Welcome. Welcome, everybody. I would like to introduce our speaker tonight, Associate Professor Peter Gonski, who will be presenting on management of pain and behaviour difficulties and delirium in aged care. Associate Professor Peter Gonski has a 30-year experience in the care of elderly patients, being a founding father of Southcare. He's a senior staff geriatrician in southeastern Sydney local health district. His passion is the holistic management of older people, been very involved in the development of models of care so that patients are treated with the right treatment in the right place at the right time. He's the Clinical Stream Director of Aged Care and Rehabilitation for the local health district and conjoint Associate Professor in the Faculty of Medicine, Uni New South Wales. He sits on a number of committees of the PHN as the local health district representative. I welcome him. I'm sure it will be a great talk. Thank you.
Okay, thanks, Phil. I hope everyone can hear me. Welcome. When I was asked to talk on this topic, I wondered what is the connection between pain management and behavioural disturbance and delirium. And when I thought about it a little bit more, I realised that this has probably been put together because of the increasing concerns about using opiates and antipsychotics. And I thought that was a big situation risk in general practice and in aged care medicine. But what I wanted to do is basically divide the talk initially into two parts, and that's pain management in the elderly, and then talk about delirium and behavioural disturbance. And then there's a little bit of connection with the drugs we use in pain management and delirium and behavioural disturbance. So the learning outcomes for this talk are to understand the principles of pain assessment and management in the elderly, be able to make a diagnosis of delirium, understand the principles of managing delirium in the elderly, and determine the effect of medication impact in the confused elderly. So we're going to start with pain assessment and management in the elderly. And just some very important points regarding this, and that is that pain is very common in the elderly, and which something that might be a little bit different to younger people is that we often can find an underlying medical cause of that pain. But sometimes we have to assess how much of what we found is actually causing the actual pain, and that can be quite difficult. And therefore, the assessment of clinical symptoms versus the pathology that we find often on imaging is totally a necessary part of determining what's actually going on. I think it's incredibly important to distinguish nociceptive pain, that is local pain, versus neuropathic pain, which is incredibly common in the elderly, whether it's due to peripheral neuropathy or post-herpetic neuralgia, or most commonly the neuropathy related to impingement of nerve roots, particularly in the back. The other thing is that's so important in the elderly is that analgesics do cause a lot of side effects, and opiates can cause major problems in the elderly, but we can also use them safely. And as I'll allude to here, and when I talk about behavior disturbance and antipsychotics, they are incredibly important in the treatment of pain. So in assessing the pain in the elderly, the first thing is that we do need to do a full geriatric assessment, which is something that we need to do for any symptom problems in the elderly. And I always say that we go back to our medical student days and we take a history and we find out what the actual symptoms are. And that way we can actually determine what's actually bothering the patient. And that's so important because we have to then match that with what we find on examination and investigations. So the symptoms are important, the past history of the patient, particularly if that you have. I think there was a problem with my audio, but it's just reconnected. The comorbidities that patients have, the medications that they've been on and they are on currently, and the side effects they've had and the benefits they've had. And it's also important, and this is our holistic approach to geriatric assessment is to look at the social situation and also the environment that the patients live in. Very, very important. And then we do a physical examination, and this is a full physical examination, but with pain, it's particularly related to where the pain is. And if it's neuropathic pain, we do need to do a full neurologic examination, but it is very, very important to do an examination. Then we would do investigations which need to be absolutely targeted to the patient's pain. The mental state before you treat them is really important, and it's not enough to ask a few questions about how they are and what day it is, but a little bit more with regard to cognition. So we do have a good feel for whether they have some cognitive impairment, because if we're going to introduce analgesics, we don't want to then afterwards think, well, did they have some cognitive impairment before? Because they certainly have cognitive impairment now. But more importantly, I think, is affect. And people with particularly chronic pain tend to get very depressed. And if they get very depressed, their pain control is much worse. So often you have to treat the pain, but also the affect. And often it requires both direct treatment of the pain, but also possibly antidepressants or some psychological involvement as well. So that's really important. As the longer it goes on, the worse the pain gets, and therefore the patient feels much worse. And if you just target the pain itself, you will not get anywhere at all. You have to target both. But the bottom line is not only the pain, but it's the functional deterioration that people get, not only from the pain itself and the underlying cause of the pain, but also some of the drugs we use. And we have to be very, very clear that the medications in the elderly that we give them can cause as much a problem as the pain or the problem they've got. And I often say that geriatrics is fairly rewarding in that if you give them some type of medication for something, they either get better or they get worse. And if they get better, that's great. And if they get worse, if you stop the medication, they will actually feel better again. And that makes them feel great. And you're suddenly a star again. So we don't lose. So when we talk about pain, we have to think about that we may be using opiates, and we really need to be careful with who we give them opiates to, because even in the elderly, there's an addiction possibility. And you can often get that from people who've got addiction behavior, people who smoke a lot and refuse to stop smoking, people who drink a lot of alcohol and refuse to stop alcohol despite it causing big problems, and people who are on benzodiazepines, of course. And those addictive people will probably become opiate dependent too in many situations. So one has to be really careful of that. And therefore, opiates have to be used in small doses, they have to be monitored, they have to be reviewed, and hopefully be stopped when the person is much better. And the other thing which I alluded to earlier is the importance of affect and the importance of depression. Now, there are a number of depression tools one can use, particularly the geriatric depression tool. And that's a really, really good tool. It's very easy to use. It doesn't take long. But really asking people if they are depressed and how they're feeling generally and how they are in life and what they're like when they wake up in the morning, whether they want to get out of bed, whether they're got anything to live for. There are enough questions to realize how depressed people are. And they'll often tell you that the pain's not getting better and it's really getting them down and they don't want to live. And finally, in assessment of pain in the elderly, as it is with anyone with pain, one has to document very well in your notes where the pain is, how bad the pain is. Now, we tend to use numeric pain tools, and that's usually the one that people use, 0 to 10, 10 being the worst. And it's really helpful in your notes to put where the pain is and what is out of 0 to 10 the pain severity is, because when patients come back, they might have forgotten how bad the pain was, and you can actually indicate to them. So there might have been 9 out of 10, and after treatment, 5 out of 10. They've done really well. You might want to get them down to 1 out of 10. But at that point, they're still doing pretty well, and yet they may not remember how bad the pain was. So documentation is really good, and you can then show them your documentation. So in the management of pain in the elderly, the most important thing is to diagnose the reason for the pain. And as I said, in the elderly, it often does have pathological pathology underlying it all. Now, in the management, one does have to talk to the patient and ask what their goals are. It's really important to get goals, because you may not be able to get rid of the pain completely, but you may be able to improve the pain and functionally improve them because their pain's a little bit better. And with many patients, elderly patients, they like their carers to be involved, they like their families to be involved. However, there are others that don't really want their carers to be involved, and you have to find that out from a patient, particularly if the patient obviously has capacity to give you that answer as to whether they want their carers involved. Treating pain in the elderly with dementia is a different situation, and I'll come back to that. One really has to start right from the beginning in assessing the risk of drug complications and who's going to get complications. I think that there are a number of personalities that really you can just about pick who's going to get the complications and who's not. But obviously you do have to know the patient's history, the medication history, their history of complications from drugs previously. And it's often, as it is with antidepressants, if you know that they did well on a drug years ago, it's definitely worth trying that particular drug again. You really need to know their opiate use, their abuse, the benefits of opiate use in the past, and the side effects that they've got from the opiate use. Now, I keep on mentioning opiate use because we often do have to use opiates in the elderly, and therefore you really need to hone treating pain. And we lost a connection. That's when I stopped. In treating patients you really need a multimodal treatment plan. It's not all about pharmacology. It's not all about opiates. It's a lot about other things as well. So we firstly look at the diagnosis and see how we can treat it. And non-pharmacological treatment, whether it's massage, whether it's hypnotherapy, whether it's acupuncture, is really worthwhile thinking about because the side effects are so much less. I would suggest that one considers local therapy if you're going to use pharmacological treatment, and I'll come to that. Systemic therapy that may need to be used, and that's obviously medication, either orally or topically. You must assess the psychological aspects of it and possibly talk about those, possibly use counseling if you need to, and possibly use antidepressants. I think one should consider using allied health involvement such as physiotherapy, occupational therapy, and it's incredible how beneficial socialization is. So if someone has got chronic pain and they're functionally deteriorating, if you send them to an exercise group after COVID, unfortunately a lot of the exercise groups aren't happening, but after COVID, send them to an exercise group. Not only will they improve their pain, their function, but because of the socialization, they will improve their general quality of life. And of course, this basically allows them to improve their pain as well. So it's all about a multimodal treatment plan. And I must say that never do you have the same plan for the same patients. So just going back to non-pharmacological treatment, which is definitely worth thinking about, I think hydrotherapy can be really beneficial. I mentioned massage and ultrasound can be helpful. Physiotherapy, chiropractic therapy in the right patient can be beneficial. Osteopathy goes with that as well. I've mentioned occupational therapy, particularly looking at how people are seated, how they, whether they can, with their pain and function, can they get out of bed, can they get onto toilets, and all that, those functional assessments and providing help through aids can be very, very helpful. But seating is really important because a lot of people get pain when they're seated. as I mentioned, socialization can not be underestimated. It really is helpful. And it is said that anyone who lives with someone with chronic pain has chronic pain themselves because they have to care for that type of person with those problems. So carer support can be really incredibly helpful. Now let's go to pharmacological therapy, because that's really what a lot of medical practitioners think about. And again, I stress that local therapy is much better than systemic therapy because of the side effect profile. And I am really a fan of injections. Now let's just talk about something like sciatica, where people get severe pain going down their legs, particularly. And I can tell you this is an incredibly common problem in the elderly because osteoarthritis of the back is just so common. And I think one should really think about if you have root pain, neuropathic pain from sciatica, you should be thinking about local root injections, which tend to be a combination of an anesthetic and steroids. Now, the place where these are placed should be done by a very competent radiologist who does these things all the time. And also, the injection needs to be placed to make sure that it matches where the pain is and not where the pathology is. And that's really, really important. And I alluded to that previously, that there might be a lot of pathology on scans, but you need to give the injection in the right place. So that way, you really need to know your dermatomes, that particularly L4, 5, so L4 on the inside of the leg and L5 at the outside of the leg and S1 at the back of the leg, and they're the commonest. But you may have L3, which goes to down the front of the thigh to the knee. All of those are important, and you really need to talk to the patient about exactly where the pain is. And patients are pretty good at telling you where that pain is. Then you send them to a radiologist who basically injects that particular route, because you tell them which route to inject. They might say, oh, we want to inject another route as well because it looks so bad. But I think they should probably not do that until you see the effect of the route that you've indicated from the history you've taken of where the pain is. Now I've got up there cement, and that is related to vertebroplasty. If someone has severe pain from acute vertebral fracture, vertebroplasty has been found to be very, very beneficial if they have extremely severe pain and the pain has been there less than 6 weeks. It's usually from a fall, but it could be from a cough or picking up something and they suddenly get terrible pain in their back. And if they are so incapacitated, they should be considered for cement. And we can talk about that later if anyone's interested. But I really have had very, very good benefits from that. In our district, the best person to do it is over at St George Private, Dr. Bill Clark. And we have done some fantastic studies on this that have shown that versus placebo that this really works. Unfortunately, whether you're talking about root injections or you're talking about cement in the back, there is a lot of controversy in the literature, and there's not a lot of data on the anesthetic and steroid injections, but we know that they do help because we see these patients all the time. And with regard to cement, there are some studies that have said that it's not beneficial, but those studies are much longer term studies. They've taken patients with pain for maybe even months and put cement in, and they haven't put enough cement in, and it's just too late for that cement to be a benefit anyway. So there is controversy, but I can tell you there is a lot of good evidence with the vertebroplasty situation. Now, if people have very local back pain and it's very severe, then the best thing is to get a bone scan and see which facet joints light up. And with an anesthetic and steroids, injected into the facet joint, that can give them a lot of benefit. So that's not a root injection, which is good for sciatica. That's a local facet joint injection. Now, with the anesthetic and steroids, the anesthetic will give a really good benefit over the first 6 to 12 hours, and patients are really very happy with that. And that suggests if they get that benefit that it's going to work long term, because then the steroids start taking over. And it takes about up to 2 weeks for the steroids to reach their full effect. Now, there is local therapy that can be used as topical therapy, and some of you have probably used it. There's one of them is called the Versatis patch, or the 5% lignocaine patch. That was developed for people with postherpetic neuralgia, and you can just put it over where they have the pain, and it's really a very local anesthetic. It is very good. We tend to use it in a hospital if people have a rib fracture. We put it over the top, and it does minimize their pain a little bit, such that they need less opiates if they're in a lot of pain. You can use it in other situations. I've got a few patients that I think dress up as mummies with it because they think it helps every bit of their body, but it is quite expensive, so I don't think they can do that long term. Now, the benefits of paracetamol in paracetamol-naive patients can be quite dramatic. There again is quite a lot of controversy, particularly coming out of Tasmania, where the paracetamol is good for osteoarthritis, particularly of the knees. But I do find that in paracetamol-naive patients, it can be very, very beneficial. And when you use it with other medications, it can be certainly quite synergistic. Non-steroidals and COX-2 inhibitors are often not used in the elderly, and that's because they often have hypertension or they've got renal failure, and they shouldn't be used in patients like that, particularly patients who've got edema, significant renal failure, and poorly treated hypertension. However, if you have a very fit patient, elderly patient who doesn't have any of those things, it's definitely worth using these medication, particularly for osteoarthritis or for sciatica as a trial, but definitely worth a try in many patients. So don't avoid them completely. If you do have renal failure and you've got a lot of inflammation, such as inflammation from gout, inflammation from osteoarthritis, even those facet joints, you might consider you my audio seems to be going down quite a lot, so I'm just stopping and then restarting. Prednisone is very well tolerated, particularly if you use it. We often use it in doses of about 15 milligrams for gout, for osteoarthritis, and as long as you wean it and you follow it up, it really is very well tolerated. Obviously, long-term prednisone has its problems. We often then go on to long-acting opiates, and again, there's a lot of controversy as to whether we should be using this, and I think that's more around the fact that people maybe become more addicted to them, and then we can't get them off it. But really, if you have chronic pain and you have pain every day and you have it morning and night, long-acting opiates are better to use than short-acting opiates. But if you're going to use long-acting opiates, particularly when you're going to start long-acting opiates, you really have to have breakthrough as well, and you really need to be giving patients some short-acting opiates to use if you're instigating long-acting opiates, so that you start feeling what doses they need for the long-acting opiates. I want to go to medicinal cannabis a little bit later, just because it's obviously new medication that we're using, and I've got quite a lot of experience in it now, and I'd just like to talk a bit about that as well. So let's just talk about opiates again. I mean, there's lots of opiates out there, and I've got them on the screen: tramadol, codeine, oxycodone, Targan, which is a combination of oxycodone and naloxone, morphine, tapentadol, fentanyl, buprenorphine. And as you know, fentanyl particularly is really frowned upon now, and even buprenorphine has its limitations, but it can be very, very useful. Tramadol, I don't use at all. I know a lot of people do. I'm just concerned about the side effects, particularly the combination tramadol and SSRIs and tramadol and NSRIs can cause a serotonin syndrome, which is significant. Many of you may not have even seen the serotonin syndrome, but a little bit of confusion on tramadol and an SSRI, you would realize that it does have that side effect. But severe serotonin syndrome can be absolutely devastating to patients. And I had one patient who came in on a combination who was incredibly confused, had fevers, and really was very unwell with it, systemically unwell from the fevers. So you have to be a little bit careful. And the metabolism of tramadol is very variable, as it is with codeine. Codeine metabolism in the elderly is just so variable, and I don't tend to use codeine. Oxycodone's much more easy to use. Morphine's probably the easiest to use. The number of different preparations, short-acting, longer preparations. What a lot of people don't realize is that milligram for milligram, oxycodone is 1.5 more potent than morphine. So 5 milligrams of oxycodone equals 7.5 milligrams of morphine. Morphine's got such a bad stigma in the community, yet I would suspect that oxycodone should really have a worse stigma. Targan the oxycodone and naloxone. Naloxone's meant to block the constipation problems, and it is important that you don't use it in liver failure, because what happens is that the oxycodone is not metabolized in the liver and goes to the brain and causes the opiate effect and the pain benefit, and naloxone is highly its effect. Oxycodone has its effect in the brain, but naloxone doesn't. So it blocks the opiate receptors in the gut, so you don't get the constipation. But it doesn't go up to the brain, so it doesn't block the oxycodone benefits with the pain side of things. So if you have liver disease, of course, the oxycodone and the naloxone go up to the brain, and then naloxone just blocks the oxycodone effect, so it's useless. Tapentadol is a new drug or a newer drug, and I think it's very useful to have it in our toolbox. It's quite good for neuropathic pain. It's got a lot of noradrenaline effect and serotonin effect, and therefore it could improve. Fentanyl is a very strong, and therefore it has to be very carefully used in the elderly. Norspan or buprenorphine patch is very useful, particularly when patients have got a lot of oral medications, and putting a patch on can be really useful. It's very long acting, which is really helpful. And it's particularly helpful in renal failure. And if I have a patient with renal failure, I'd be tending to use hydromorphone or buprenorphine. They're my two choices. So you've got a choice of oral, you've got a choice of topical, and of course, at times we have to use subcutaneous, particularly at the end of life care. But that's very beneficial to have all those available. The side effects of opiates tend to be mainly gastrointestinal, particularly constipation, but also nausea and vomiting. Constipation is very common. You have to ask the patient because they may not realize it's from the opiates. And even the long-acting buprenorphine patch can definitely cause it. So one has to be a little bit careful with that. Tapentadol may have a little bit of benefit there. It also causes constipation because it is also an opiate, but possibly less constipation than some of the other opiates. Now, confusion is a problem in the elderly, and every single opiate can cause this, and we often find it with our patients, particularly if they've had acute events and they could be heading towards delirium anyway. So one has to be really careful, and often we'll stop these drugs if patients get confused, if they haven't been on them before. Drowsiness is a problem, and therefore falls is a problem, and this can cause loss of function or decreased function. Hyponatremia is a fairly rare side effect of opiates, but is a problem as well. And hyponatremia in the elderly is very common and is associated with increased confusion and decreased mobility and increased falls. So one has to be careful. So one has to decide, if you're going to use opiates, are you going to use long-acting versus short-acting? And I think that for chronic pain, one should be thinking about long-acting and starting them with a little bit of short-acting breakthrough and then possibly increasing the long-acting dose. Confusion and constipation have to be really thought of and asked. You have to ask your patients because often they don't realize what's causing their confusion or their constipation. I think you have to give them a trial and error type situation and just wait and see how people go. But always start very low and then slowly move up, possibly every week or every 2 weeks. I said that breakthrough analgesia is often required if you're using long-acting doses. As I said, morphine has an unfair stigma because it's probably easier to use and probably more safer than a lot of other drugs. Now, given tapentadol slow release has come on the market, there's often this question of whether we should be using Targan versus tapentadol, and I'm not going to go into that debate very much, except to say that they're very useful, both of them, and if people have had side effects, possibly with Targan, you might want to use tapentadol and vice versa. What I will tell you, though, is that if you stop Targan and start tapentadol, some people do get opiate withdrawal. Targan is a stronger opiate, and therefore one has to be very careful. And I've done that with one patient, and they really had a terrible withdrawal situation. So just sort of basically stopping Targan and putting them straight on tapentadol can be a problem. I've mentioned renal failure. I've mentioned liver disease and how one must not use Targan in that situation. And we've now got to the situation that there is severe restrictions on prescribing. Now that's making our lives very difficult. It's particularly, I know that a number of particularly general practitioners have decided they don't really want to provide opiates at all. I don't think that's reasonable because a lot of patients have been on opiates for a long time. They can't be just stopped or abandoned. And many of these patients should be continued on their opiates. However, I think the restrictions are a good thing because we've all started to think about looking at our opiate prescribing and trying people on smaller doses and smaller doses. And even in hospital, in patients who've had chronic opiates, I'm trying to get them onto lower and lower doses. It's very hard sometimes, and patients cling to their opiates, but really we should be trying to get people off them. And I think that the restrictions on prescribing does make it a little bit difficult. Now I want to go to medicinal cannabis. Now, I asked this question, is there evidence for medicinal cannabis or is there just a major placebo effect? And I don't know whether the elderly are starting to think it's cool to go into medicinal cannabis, or they've tried so many other drugs that they want to try it. But there are a lot of patients asking for it, and there's a number of patients that I'm offering it to. Now, is it hard to become a prescriber? The first time you have to put in a lot of information about yourself, but once you save that prescribing information, next time you come on, that prescribing information is there, so it's not so hard. You do have to get TGA approval, which is not that hard, and the more you prescribe the drug, the easier it is, and I've got TGA approval within 24 hours for some patients. It is a Schedule B drug and not a Schedule A drug, so you have to say that. And you have to tell the TGA why you're giving it. And basically, there's a whole lot of reasons that you're allowed to give it, such as chronic pain, such as neuropathic pains, such as anxiety, such as severe anxiety, depression. There's a number of, if you go on the TGA website, there's a whole lot of reasons why you're allowed to prescribe medicinal cannabis. And I saw a patient with Ehlers-Danlos syndrome recently, out of the blue. Some of you will know what that is, and it's people who've got really significant joint abnormalities that they can do every trick in the book with their joints, and they get very weak skin, and they can do tricks with their skin, but they do get a lot of chronic pain. And I was surprised that Ehlers-Danlos syndrome is one of the indicators for medicinal cannabis. So you sign up as a prescriber, and any doctor can do it. It doesn't have to be a specific doctor. And you save your information, and you put the information of the patient in. As I say, the first time is a little bit more difficult, but after that, it's much easier. Now, there's about 120 different medicinal cannabinoids. We tend to use THC or CBD. I think a combination for pain is the best way to go. However, in Australia, you're not allowed to drive if you've got THC in your blood. So if you have someone with chronic pain who you want to give medicinal cannabis to and they're still driving, you have no choice but to give them CBD, which is a problem because the THC combination, I think, is much better for pain control. CBD seems much better for anxiety. So, and people tolerate CBD really well, and you can go into really high doses of it. And there's some prescribers in New Zealand who've prescribed at least 300 patients of CBD to 300 patients with either pain or hepatic pain, and they've had very, very good results. How much is that placebo? How much is it benefit? I don't know. But in my practice, I've prescribed about 36 patients, and I'd say about half have benefited according to them. And the other half basically, interestingly enough, have not got a lot of side effects, but they've just decided it's not beneficial and they don't want to pay the money for it. So the side effects tend to be nausea, tiredness, and confusion. As I say, a lot of my patients haven't got it. I start very low doses and move up very slowly every few days. It is costly. If you use really small doses, it's not costly because you're using, basically, you can go through a bottle of 40 mils in maybe 1.5 months or 2 months rather than 1 month. THC and THC and CBD combination is about $160 a month if you use a reasonable dose. CBD is a bit cheaper than that. Okay, so THC I tend to use in pain if the patient isn't driving. It is a bit more expensive. CBD, good for anxiety. Patients can drive and it's a little bit cheaper. Now I want to go through a little bit about patients with dementia and pain, because sometimes it's really difficult to assess these patients because someone will tell you they've got a lot of pain and when you actually ask them, they don't remember. So if you can be at the time, you can be there when they've got the pain, you have to ask, where is the pain? When do they get it? And what does it actually feel like? And only when they've got it will you get that answer. There are some tools that you can use to assess severe pain, pain in severe dementia. There's called the Pain Ad tool, which is really good. There's, as you've probably seen, some of you, that there's that tool where patients can point to whether they've got a smiley or a sad face. But the Pain Ad tool is more about people looking at patients and seeing whether they're grimacing, what they're doing, whether they've got behavioural disturbance, etc. And that's a tool of observation. It's not a tool where you're involving the patient directly by talking to them. The medications we use, particularly opiates, one has to be really careful about. So local injections and all that sort of thing are much more beneficial because they don't give the side effects. So be very careful with opiates in patients who have dementia. Again, PRN use is pretty useless because unless the nurses are there in an aged care facility or something like that and can see they're grimacing or they see them when they actually got pain, it's really difficult to use PRN in patients with dementia. So that's when we tend to use long-acting drugs, which are much more beneficial. I think that people have moved towards using morphine for patients with behavioural disturbance because they say, oh, their behavioural disturbance must be due to pain and therefore should give a trial. I think this is over-treatment. In many patients I've seen on morphine for a morphine trial, I haven't seen any reason why they've got pain at all, and I often stop it. In about 20 years ago, there were a number of trials and a lot of papers on this and the use of morphine in behavioural disturbance, but I don't think that was a pain control situation. I think it was basically just making patients maybe feel a little bit less anxious or feel a little bit better generally. So this is my conclusion on the pain side of things, and then we're going to go on to delirium, and that is you really need a very good holistic assessment of the patient and take a good history, take a good do a good physical examination and good investigations. And when you get investigations back, try and make sure that those investigations fit where the pain is. And that holistic assessment may include other people such as physiotherapists, occupational therapists, psychologists, etc. A multimodal management is the way to go, including non-pharmacological and pharmacological treatment. And where possible, avoid opiates, but don't say to yourself, we're going to completely avoid them in all patients, because many patients do benefit from these drugs. Now, the dreaded Ds of aged care include delirium. So I'm going to go to delirium now. And these are the dreaded Ds, although I know the last one isn't a D, but possibly is part of dementia, is mild cognitive impairment, is possibly very early dementia. But these are the Ds that the patients don't want to have: the dementia, the delirium, the depression, the dysphagia, and the deafness. But we're going to particularly talk about delirium today. So making diagnosis of confusion in the elderly, and that's usually delirium or dementia, one has to take a really good history. And that history must include how long has the person been confused for. And if the confusion is very short acting or a short time, then it's going to be delirium. And if it's longer, it's on the whole going to be dementia. And in those patients, it's usually deteriorating and progressive. There are some patients who perhaps may be on a anticholinergic or something like that, who's become confused over some months, and when you stop that, they get better. But that's a rare event, and they certainly don't have dementia. But on the whole, patients who've got chronic dementia, chronic confusion, are going to have dementia. Acute confusion equals delirium. Now, on these patients, you do need to do a full examination to see why they've got delirium, and you must also do a neurological examination to see whether they have signs of chronic neurological disease, which may be consistent with their dementing illness. And also you need to do some type of cognitive assessment. But in delirium, that can be very variable, and you can actually have a very different cognitive assessment in a morning or an afternoon, or a day, one day to another day, which doesn't quite fit with dementia. In dementia, particularly vascular dementia, some carers say that people are better one day or the next, but then they'll deteriorate possibly another day. The investigations are really common and important, but they're very, very simple investigations, and they tend to be related to imaging. So here's a little assessment for you, just to give a little bit of a break in my talk, and that is, here's an assessment of a person who can't speak but babbles, is incontinent of urine and feces. He tries to walk, but he often falls over. And the question is, does he need a nursing home? This is just a little assessment for you. And the answer is no, because this is who I'm talking about right now. And why do I put up this slide? Not because I've just become a grandfather, but because if you don't have all the details and all the information, you really can't come to a diagnosis of delirium, dementia, and the cause of confusion in the elderly. So in this case, this is a child, and if we go back to the history, he can't speak but babbles, he's incontinent of urine and feces, and he tries to walk but often falls over, and I don't think we're going to put him in a nursing home. So you need all the information you can get. So the tips about confusion in the elderly include taking a really good history, and that's usually from a carer or support person or someone like that. And the duration is the most important question. Many times they'll tell us they were fine yesterday, they weren't confused, but they're absolutely confused today. And we may not believe them, but they're quite true that they've got a delirium and we have to treat the delirium. And if we treat the delirium properly, they'll get better and possibly return to their pre-morbid state. Have there been any new recent symptoms? And that we really need to ask about everything. Has there been a new cough? Has there been new chest pain? Has there been abdominal pain, etc.? Because they might be clues of why someone's cognitively deteriorated. And whether they've got some short-term memory loss chronically, which suggests that possibly they've got some dementia underlying all this, but perhaps it's got worse acutely, and therefore they've got delirium on top of their dementia. The examination, again, has to be very complete, and it has to be a general examination. And in delirium, it's so important to listen to the chest, feel the tummies, look at the skin, and make sure that there's no other abnormalities. And if I could just also put in the fact that you should look into people's mouths, because often people don't look after their dentition, and this could be a cause of infection and delirium. And even today, I've got a patient in who's actually fairly young who came in with delirium, and I was telling the students that you must look in their mouth, and the patient's teeth were just awful, absolutely awful, and they came in with sepsis. And I didn't know, but the dentist rang up and said he knew that he was going to remove all the teeth next week. And it just confirmed that this person's delirium was probably from poor dentition. And we gave him antibiotics, he got better, and he's going to have his teeth removed next week. So all of this is really, really important, a full examination. And then we go to simple blood tests. And this should include electrolytes, full blood count, renal function, obviously. And if they're on medication, it might include medication levels such as phenytoin levels, carbamazepine levels, digoxin levels. All are important because they might be a clue to why the person's got delirium. We tend to do CTs of the brain. We don't usually do MRIs if we think delirium. But sometimes if we're not sure, we might do an MRI just to check that there's no little bleed or something like that. And we sometimes do EEGs and do lumbar punctures, but they're fairly rare, and they're in cases where we really don't know what's going on. Now, what about mini-mentals? These are the three people tend to use, and if I could just talk about them very quickly, and that is the Falstein mini-mental is a very, very good test, but it's particularly useful for patients with Alzheimer's disease. It has its real drawbacks, and that is it doesn't test frontal lobe function. And so in other types of dementia, other than Alzheimer's disease, it really doesn't pick up abnormalities very well. Alzheimer's disease, particularly a condition of short-term memory and orientation problems, and Falstein picks that up pretty well. However, if people are from other cultures, you might want to consider using the RUDAS, which is much better in patients who are not from Australia or who don't speak English particularly well. But I do not see why people use RUDAS in patients who are from Australia or speak very good English. The Falstein should be used in that situation if you're going to use a mini-mental. The MOCA is much better if you're looking for frontal lobe dysfunction, but recently the people who wrote MOCA actually sent emails to all of us and said, well, you have to pay for it, and also you have to undergo education for it, and you have to do a test at the end of that education, and if you're good enough, you'll get a certificate, and then you can use MOCA. I actually haven't used a lot of the MOCA. I tend to use Falstein, and I do some frontal lobe testing of my own, and that can be really, really helpful, and you certainly don't have to pay for any tests. But just know the limitations of these tests if you're going to use them. They are beneficial. Don't forget they are tools. They're not diagnostic of dementia or delirium. And all of them change a lot if you've got a delirium situation, because delirium fluctuates so much from day to day and even hour to hour. What about imaging? Well, we do CT brains. They're simple. They're very non-sensitive, but they are useful to tell us if there's a big bleed or a big infarct or something like that. MRIs are much more useful and can be really helpful in situation of confusion in the elderly. Quite useful. So we use FDG PETs. We tend to use the St. George ones at St. George Private. They are $800 without Medicare rebate, unfortunately, but it's really helpful in actually telling us which parts of the brain are not working and which ones are working, because in Alzheimer's disease, you get a particular picture of the hippocampus not working, whereas in frontal lobe dementias, you get the frontal lobes, and in other types of dementias, you get other abnormalities. The EEG can be useful in delirium. If someone's really delirious, they're really abnormal. If you're not sure whether someone's having mental health issues versus delirium, then they're usually normal. And if someone's got dementia, they usually show a lot of slow wave abnormalities, so that can be useful as well. Now there's amyloid label scans. There's an amyloid MRI at Macquarie Hospital. It costs about $1,000 to $1,200 without Medicare rebate. I don't suggest them because if you've got amyloid in the brain, it doesn't mean you have Alzheimer's disease. Alzheimer's disease is a clinical diagnosis of memory loss plus amyloid in your brain, but it's only a helpful test. It doesn't diagnose Alzheimer's, which I think, is a concern because when patients have these amyloid scans and they're told they got amyloid, therefore they got Alzheimer's, that's not right. They might be at high risk of Alzheimer's in the future, but that doesn't mean they've got Alzheimer's. And finally, lumbar punctures, which we rarely use, but apart from in specific situations such as Creutzfeldt-Jakob disease, that's mad cow's disease, where it can be quite helpful when used with EEG and MRI. Now, if anyone has confusion in the elderly, delirium needs exclusion, particularly if they're acutely confused or even subacutely up to maybe a month or even up to 3 months confusion. One has to be thinking, is this delirium or is this dementia? People with delirium have very poor attention spans. They're all over the place. They often don't even finish talking to you, or they get onto something else as well. Whereas people with dementia, often you can talk to them. What they say is wrong or abnormal, but really you can have a good conversation with them. Whereas people with delirium are all over the place. They often have psychosis. They might have visual hallucinations of visual moving targets, that is rats or bugs, and you often see them sort of going for it and doing sort of feeling for things, or they have possibly some paranoid delusions they might have as well. Interestingly enough, in delirium, on the whole, people have an underlying medical cause of their delirium, which includes infection, metabolic impairment, and medications. There's two types of delirium. There's the hypoactive one, where someone's basically either very sleepy or sleeps a lot or really just lies around. And then there's a hyperactive one where someone wants to be agitated and often wanders, even around the home or the aged care facility or the hospital. The hypoactive one is often missed because people are just lying around and you think, oh, well, they're just tired. But they're the problem ones because in hospital particularly, they're often overlooked and they're not moved. They may get pneumonia, they may get pressure areas because no one really is thinking about them because they're very well behaved. Whereas the hyperactive ones, people know exactly what's happening with them and they chase them or they try and settle them down. So they get plenty of help. As I said, in a severe delirium, an EEG can be helpful because it's usually abnormal, except in the case of a very severe dementia where you get slow waves. So the cause of delirium are multiple, but the three groups that one has to exclude are infection, and everyone knows about urinary tract infections, and it is the commonest cause, but there are often other infections around. There's lungs, such as pneumonia. There's gallbladder disease, which I don't know, for some reason during COVID seems to be absolutely rampant. We've never seen so many gallbladder diseases in our elderly population in the last few months. I don't know why. Bowel infections, either diarrhea, gastroenteritis, or colitis. The skin, cellulitis, teeth I mentioned. Everything that's abnormal in the patient, such as any prosthesis, knees and hips and pacemakers, they all get infected. So we have to think about all those things, and you're allowed more than one infection, of course. The metabolic is quite common. Hyponatremia is very common in the elderly and it causes confusion. And I'd be worried at anyone below about sodium of 128 if it's chronic below 126. But there is good evidence that these patients are more confused with their hyponatremia and more likely to fall over. Other metabolic abnormalities include acute renal failure, hypoglycemia, particularly in diabetics who are taking too much treatment, liver disease, so you should look for a flap, and a hypercalcemia. You should always do a calcium. And primary hyperparathyroidism, although it doesn't often give really high calcium levels, it is very common in the elderly. Medications started and stopped. So the medications that are often cause confusion when they started are the opiates, L-Dopa, antidepressants and antipsychotics, which is a bit of an interesting one because we often use antipsychotics because people are confused, but particularly the ones with a lot of anticholinergic effect, such as olanzapine, they can actually make more confusion. But don't forget the stopped medications, particularly the benzodiazepines. Someone doesn't have a benzodiazepine script, or when they come into hospital, often they're nil by mouth and they don't get their benzodiazepines. And a lot of these patients have been taking them for many, many years. And whether alcohol is a medication or not, or a drug, or just a nice beverage, the alcohol in the elderly is rampant. And stopping it for some reason, whatever it is, can cause a significant delirium. And as I mentioned, if you have on board digoxin, phenytoin, carbamazepine, you can have toxic levels. And a lot of the anticonvulsants are in this situation. So Keppra is one that people can get quite confused with. Now, there are lots of other causes of delirium. I'm not going to go through all of them, but be aware that anything can cause it, even from someone having a flu vax. But surgery is a common cause of it in hospital because of the anesthetic, because of the analgesics, the opiates they give, them waking up in an environment that they're not sure about. There's lots of reasons why surgical procedures are subsequently complicated by delirium. A little bit of dehydration in older people causes delirium. We so often see it, and the renal function may not be even all that abnormal, even when you do the test. So, you know, people approaching, we're going into summer, one has to keep patients pretty hydrated. And yet often we're saying, don't drink too much because you're going to get leg edema or heart failure. Constipation is not uncommon in the elderly and can cause delirium. Epilepsy is an interesting one because it's not the tonic-clonic type epilepsy. It's the patients who are walking around, who are confused. We do an EEG because we can't find anything else, and they have non-convulsive epilepsy, that is status epilepticus. It's a really interesting one, and you give people anticonvulsants and they stop being confused. Bereavement has been well documented, and that's usually when a carer dies and the demented patient is left to be looked after by people who don't know them, and their confusion level really increases, so they get a delirium. Change in environment's enough to cause delirium. Silent myocardial infarction or silent minimal hemorrhage in the brain can cause these things, and there's lots and lots of other causes. So just think of anything. That's why you should do a system review on these patients. Now, what's the management of delirium? Well, first of all, it's making the diagnosis, delirium versus dementia or depression. Diagnosis is so important. And then you have to go looking for the medical cause. And if you find the medical cause, you treat the medical cause. But you have to treat these patients in the right environment. And the best place to treat person is in their home. So if they live in their own homes, they should try and live in their homes with support. If they live in aged care facilities, they should try and stay in their aged care facility. Although many do end up in hospital, and you just see that their delirium initially gets so much worse because they're in a new environment. Many a patient has been admitted for something else to a hospital, not in a delirious state, and the next day they're incredibly confused. So try and keep them in their own environment. And when we do treat them in hospital, we try and treat them in a very comfortable environment with good ambience, good lighting, good sound, not too much noise, not too much rushing, and staff that actually know what they're doing and who are pleasant to them. The use of benzodiazepines and antipsychotics we try not to use, but I'm going to come back to antipsychotics. The use of benzodiazepines are mainly useful in patients who are getting delirium from benzodiazepine or alcohol withdrawal. Now, the difficult behaviours of delirium and dementia tend to be multiple. Many patients, particularly with dementia, have got behavioural disturbance. And a common one's wandering. And the only way to treat wandering is to put them in a secure environment. And certainly antipsychotics is probably the worst way of treating them. So you put them into a secure environment where they can walk or wander as much as they like. So that might be their own home with the front door locked, or it might be an aged care facility where they can wander around, but the door is secure. Number of aged care facilities are putting pictures over the doors so they can't see that it's actually a door. So we've seen a number of aged care facilities put a picture of a bookcase, and they think that it's a bookcase. The other day I was in an aged care facility and I tried to get out and I couldn't find my way out, and then I realized the door was the bookcase and I had to get out through the bookcase. Screaming is a difficult one. It's very complex. I mean, it could be due to pain, and that's why I think a lot of people in aged care facilities who are screaming are given trials of opiates, but it's not always due to that. It could be just because they can't communicate well. They may be dysphasic. It could be because they're uncomfortable for some reason. They may be anxious, they may be depressed, or they need to go to the toilet and they can't get the staff to come quick enough. So screaming is a complex one, but it is part of the behavioral disturbance. So the way to treat that is, again, to try and determine, if you can, to put yourself into that person's mind and try and work out why they're screaming. It's not always easy, but sometimes it is easier. Physical aggression is a difficult one. Sometimes we have no idea what's going through someone's mind, but certainly if they've got delusions, severe delusions or the hallucinations, then antipsychotics can be incredibly useful in this situation. And that's why I say that antipsychotics should be used very carefully, but they do have a role. They definitely have a role. But as I say, in wandering and possibly screaming, they may not be helpful. In fact, they might be very bad to use in certain patients. Inappropriate behaviours, particularly sexual behaviours, and the other one is peeing in the wrong place. And that could be because they don't know where the toilet is. So you might have to have a big sign up saying this is where the toilet is. Or they just don't know that they need to go. And then obviously you need to have other ways of treating that, which may include wearing nappies and things like that. So in treating behavioural therapy related to delirium or dementia, we do the ABC, and that is what's before, what's during, and what's after. So what led up to the behaviour? Can you tell? And sometimes you can tell by saying, oh, someone got agitated with my patient, and that's why they got very agitated. Or someone said something to them, or someone hit them, or something like that. So it's really important to know that, because the treatment of that would be obviously to separate the people. B is actually what's the behaviour itself, and that's how did the person behave? Did they hit back? Did they scream? Did they start wandering? What is the behaviour? And C is what's the outcome of the behaviour? What happened after the behaviour happened, and how do people deal with it? And if they dealt well with it and it was a good outcome, then that needs to be documented as a good outcome and people should use it again. And that needs to be used by all the staff or the family who are looking after that person. On the other hand, if it's a bad outcome, everyone needs to know that too, because that's certainly not something that should be used. The real question is the behavioural problem due to the delirium, the dementia, or the depression, or even mania, because obviously the treatment's going to be different. Delirium, you'll have to look for the cause of the delirium and treat that. The dementia, you may want to treat the dementia, or treat the person, which you should always do, in a very individualized manner. If they're severely depressed, giving them antidepressants might take away that treatment, that behavior, or they might be totally manic, and we see this in the elderly, in which case antipsychotics and other medications, even such as lithium, which can be used very carefully, but is a very helpful drug in mania in the elderly, as long as they don't have thyroid disease and kidney disease. I saw a patient today who came to see me because of deteriorating behavior, and he was getting really agitated and shoving and pushing people and fighting. And we really determined that really what was happening was that his brain was deteriorating. He was getting more confused. His memory was getting poorer, and he had insight into that, and he was getting incredibly depressed over that. And that's why he was playing out his depression. And giving him antidepressants and possibly antipsychotics in the initial situation has been incredibly beneficial to settling him to his behavioral problem. Always try to use non-pharmacological therapy first, and that is to get to know the patient, to give them the type of therapy that they would like. So we try to find out a lot about them, and I always give the story that we had a very agitated patient who loved fishing and went fishing every day, and we gave him a fishing magazine, and every day he'd sit down and just go through it all day, back and forward, looking at these fish, and that was enough to settle him. Also, we've got patients who love gardening, and attached to our behaviour unit, we have a garden, and they go out there and they're much more settled in the garden with a rake or a broom or something like that. And then you often turn to pharmacological therapy, and just with the treatment of chronic pain, you really need a multimodal therapy pathway of behavioral therapy, and that includes non-pharmacological therapy and pharmacological therapy. So this is an incredibly busy slide, but it tells us that the patient itself is very important. You need to know a lot about the patient. You need to know about their pain, and you need to know about whether they're constipated. You need to know a lot about them. And so there's a lot of patient pointers that you can possibly alter once you know about them. So if you know their culture, you should be looking after them within that culture. So I was in a nursing home the other day, and the patient was very confused and agitated and showed significant behavioural disturbance. And when I asked the nurse what language this fellow spoke, and he didn't speak English, she had no idea. So how can we manage someone like that if the nursing staff don't even know which language they speak? And even if the patient doesn't speak is confused in their own language, at least they would be more settled if they were talked to in their own language. So the patient factors are just so important. And then there's the interaction that we have with them. So the way we talk to them, the way we gesture them, we should be talking to them softly and calmly, even if they're agitated. We should accept that they have personal space that shouldn't be invaded. We shouldn't come behind them suddenly and shock them. And that's why I think having security guards or one-to-one nursing can be very, very detrimental to the treatment, because they get very scared and more agitated. One has to be really important. And finally, the environment has to be really right for these people. And that's why I say unfamiliar surroundings are very bad for patients with delirium. It just makes it worse, so that if you can treat these patients at home, in their own home or aged care facility, they're much better off. But if you're going to treat them outside their home, then you have to make sure there's not too much noise, that it's a nice coloured area, so it's good ambience, that there's not too much noise, that there might be music, but make sure the music's nice and that it's the type of music that that population enjoys. And also, so it's not only that, but it's also the smell of it. And so the general ambience is just so important. And it's often very nice to have nice looking and comfortable environment, and they should be secure environments so they can walk around and wander as much as they like. So what are the aims of treatment in the behavioural disturbance related to delirium or dementia? Well, the most important thing is to keep the patient safe and keep everyone else around them safe, and that's the other residents, the other patients, and the staff, of course. It's just so important. It's really terrible when our staff and staff in aged care facilities and the families get injured themselves from patients who are agitated. So we have to reduce all the complications of falls and injuries to the patient who might be hyperactive and running around. We have to protect our patients and residents, and we have to protect our staff. So the non-pharmacological therapy is mainly to familiarize yourself with the person, make sure you know what language they speak, make sure you know what their interests are, make sure that you know that if they prefer to shower in the morning, then the staff should shower them in the morning. If they prefer to shower at night, they should be showered at night. It's not about the staff, it's about the individual. Try and understand them, try and get into their brains, which can be quite difficult and quite challenging. In the afternoons and evenings, they're usually sundown. So keep them busy. That's the time where all staff tend to be least. But that's when we should have our families around, our diversional therapists around to keep them busy so that they don't get more agitated. I've talked about good noise and light, and because there's in delirium, you get the people sleeping during the night, sleeping during the day and up during the night often. That's the reversal of the sleep-wake cycle, which is so typical of delirium. If you have plenty of noise and light during the day and no noise and light at night, they're much more likely to sleep. The way you talk to them, the way you respond to them, the body language that we give them is all very, very important. And really, staff and families have to be well educated. And then I want to get on to antipsychotics. The Royal Commission has really been talked a lot about it. The Royal Commission has really been pushing this side of things and how people shouldn't be on these drugs. Unfortunately, they have a very bad name for themselves now. And I think it's due to carers who've seen their loved ones in aged care facilities be over-treated with these drugs, and the outcomes have been incredibly bad. But I still believe that there is a real place for antipsychotics, particularly in psychotic patients who have behavioral disturbance related to that psychosis, and that is their hallucinations, that they're seeing things, that they are scaring them, or they're thinking things are happening, such as people are killing them, or people are fighting them, or something like that. They may benefit from antipsychotics. Always start low and regular reviews. And it's been very well shown that if you are going to use these drugs, 3 months later, you may not need them because you've changed the behavior or the person's changed, and therefore they should be probably withdrawn. But not always. Sometimes you need to try and withdraw them, and you can't withdraw them, and you have to go back on them. So these are the drugs we tend to use. Risperidone is very, very popular, probably because it's the best evidence. There are some number of studies that have shown that it's beneficial. However, in frail people, they can really have increased mobility problems and falls and a lot of sleepiness. Quetiapine's liked. It doesn't fit with the PBS for authority, whereas risperidone is on the authority for behavioral disturbance. Quetiapine is not. But the benefit of quetiapine is that it causes less side effects, and it's probably just a weaker antipsychotic. So we tend to use it in patients who need antipsychotics, patients with Parkinsonian syndromes, so that they're less likely to get Parkinson's disease or Parkinson's side effects. Olanzapine is a great antipsychotic, but it's very strong. It's particularly good in patients with depression and dementia. It's a very good antidepressant. But because it's strong, it often causes Parkinsonian syndromes, falls, sleepiness. It's probably got the worst metabolic profile, so diabetes, leg edema, hypertension. So it's a dangerous drug, but it's a very effective drug. And as I say, if someone's got severe depression in the elderly and possibly some psychosis, it may be very beneficial. People often sort of head away from old drugs, and haloperidol is a very old drug, but it's very beneficial because you can start very low doses, 0.25. It can be given orally, it can be given subcutaneously, it can be given intramuscularly, it can be given intravenously. It's a very useful drug, but it has a high side effect profile. But if used in low doses and reviewed regularly, it's a very good drug. So we tend to use that for delirium, where we regularly review it, like every day. I tend to use risperidone, quetiapine, or olanzapine in specific patients with dementia, particularly those with psychosis. But occasionally we'll even use these drugs in Parkinson's disease, even though everyone says they're contraindicated. Sometimes you really need them, and they can be very beneficial. So the problems with antipsychotics tend to be Parkinson's, falls, sleepiness, stroke, urinary retention. It should be urinary retention, and increased confusion. But the benefits are that they do settle an agitation, particularly if that agitation is caused by psychosis and when there is no trigger. So the rules of using antipsychotics are to try to avoid them. They are useful if psychosis is present. Start very low and go slow. Review the dose and side effects frequently, and often they can be ceased if used in delirium or dementia. So this is a study by Bradati et al. It's quite old now, but it did show that there is benefit of risperidone in reducing the behavioural disturbance related to dementia. So in conclusion, with regard to confusion of the elderly, make sure the diagnosis is right. Make sure you're dealing with delirium versus dementia or both, or not depression or something else. If you have delirium, find the underlying cause and treat it. Exclude mental health issues, and that's usually exclude delirium first, and then you can think about mental health issues because they need mental health treatment, whereas delirium needs medical treatment, and I mean treatment for the underlying cause. Manage the behavioral therapy non-pharmacologically if you can, but you may need to use antipsychotics, but always review them. So I've covered a lot of geriatrics, and I hope I've helped you in some of the topics we've talked about: pain management, delirium and where it fits in confusion, and how to manage those. So I think we've actually got a few minutes for questions. I'll hand over to Philip and he can head the questions in my direction. Thanks very much.
Okay, thank you, Peter. A real tour de force there. First off, one question. People who are already on dementia medication such as Reminol and that, does stopping that and they're being used for behaviour management, does that make their behaviour management more difficult? If or is it better to leave off with them when they're in nursing homes and things like that?
Yeah, I think it's a good question, but I can tell you that if you start taking away cholinesterase inhibitors because they've entered into a nursing home, you'll find that often their cognition deteriorates fairly quickly, and therefore we do not suggest that. However, if you're treating it, using it for behavioral disturbance, and actually it can be beneficial for some behavioral disturbance, the best behavioral disturbance it's useful for is apathy, and apathy is a very common behavioral disturbance of dementia. It's also quite a common in depression, but apathy is really benefited by cholinesterase inhibitors. But some of the others, you may get a little someone is deteriorating cognitively, then despite the cholinesterase inhibitors and they are in nursing homes, you may want to trial them without them. And when they're severely demented, you may want to trial without them, but generally don't stop them when they're going into nursing homes. It's a terrible time to stop them. And we tend to keep them going unless there's a reason to stop them.
Thank you. Do you have to wean the antipsychotic dose or can you just cease the medication?
Yeah, look, I think if someone's got severe Parkinsonian syndrome and they're really very, very settled, I think it's probably worthwhile stopping it outright. However, if they've got mild side effects or the behavior that it was used for treatment, is severe, then you may want to just wean it. So if you've had sort of 3 months ago someone really psychotic or really agitated and it's really done the trick, then you may just want to wean it. However, if you're not even sure why the patient was on it or it was put on for when someone had a delirium, then you really want to just stop it. And there's no harm in stopping these drugs except that you may get a rebound of behavioral disturbance, but often you will not. So I see a lot of patients in the community who look so Parkinsonian. In fact, some of them have got full-time carers at home because they can't move. And we ask them, well, why were you put on these drugs? We obviously ask the families, and we often get the medical records. And sort of 10 years ago, they had a delirium and they were started on them, well, they can just be stopped. Whereas if they had a psychotic episode due to mental health as problems 10 years ago, they may need to have a small dose, but maybe they don't need quite as much as they're on. And I've had great benefit in stopping these drugs. I've seen people go from totally dependent to totally independent. However, the other side is that I've also had a patient who's improved so much and then 3 to 6 months later reappeared in hospital with a severe psychosis. So this is the problem with the medications of the elderly, is that you want to stop them and they improve so much when you get rid of the side effects. But then you wonder, well, why did they put on them? And then 3 to 6 months later or 12 months later, you know exactly why they put on them, because they rebound with the reason why they put on them, and they often have to be put back on them again.
Thank you. You mentioned that you do frontal lobe assessment yourself to supplement the MMSE. How do you do this?
Yeah, I do a very simple test, and it's a really good test. It's so simple. It's called a tracking A and a tracking B test, and it is actually part of the MOCA. And the tracking A test is that you put A, B, C, D, E on a page all over the page, A, B, C, D, E, and the patients have to join them up in order as and they have to just join them all up as they appear in the alphabet. And most of them can do that. And then you ask them to do the tracking B test, and you do A, B, C, D, E sort of all over the page somewhere, one of each, and then you put 1, 2, 3, or 4, or 5 sort of intersecting between the A, B, C, D, and E. And they have to join up 1 to A to 2 to B and all as one line. And they really find that incredibly hard, and that tests executive function really well. The other way of testing visuospatial testing, which is a little bit different, is of course part of the mini-mental. The Falstein mini-mental is the intersecting pentagons, and also something that's not part of the mini-mental is the clock construction, which can be really useful, and they can be really interesting. So they usually test visuospatial, but I like the tracking A and tracking B tests. There are other tests. There's something called the FAB test, which is a very simple frontal lobe test that you can check up on, you can Google. And then of course there is the MOCA, which you can use, but we really don't know where that one's going because of this training, exam, and payment. So we don't know whether we're actually going to be able to use that.
Okay. When dementia and delirium coexist, are antipsychotics helpful or worsen the dementia?
Okay, so if you have a patient who has dementia and is confused, obviously, and they markedly deteriorate quickly, then they've probably got a delirium. It's probably not a progression of their dementia at that point. Often it's put down to that, but often it's not. It's a delirium. And if you can find the cause of the delirium, you treat the delirium. If they're very psychotic with that delirium, then you should use antipsychotics in small doses. And you should, once their delirium is settling, you should try and withdraw that antipsychotic. If you do it properly, the dementia should not deteriorate. However, it could be that if the delirium doesn't go completely, then that dementia is obviously worse because the patient's more confused. But generally, the delirium does settle, the antipsychotics can be removed, and you don't have the problem of antipsychotics making dementia worse. Do antipsychotics make dementia worse without the delirium? Well, they certainly slow the mind, and therefore they do make the dementia worse. And they, of course, reduce function, and they cause a Parkinsonian syndrome. They increase falls risk and fracture risk. So there's no doubt that antipsychotics make dementia worse. But with regard to delirium and dementia, if you use them acutely and properly and for short times, they really should not make the dementia worse.
Okay. One last question, it appears. What is Schedule B and what are the rules that apply to that? Is that sort of...
Okay, so it's all about paperwork.
Yeah.
If some drugs are Schedule A where you have to actually fill out a TGA form, which you often are able to get. So we use a drug called midodrine, which is for postural hypotension, and it's not TGA approved, but if you fill out a Schedule A for it, and you write down postural hypotension on it and you send it in, they will give you they'll basically say that that's fine to use it in postural hypotension. So that's a special form with special questions, and that's a Schedule A form. A Schedule B form is a different form, but when you do the prescribing of medicinal cannabis online, all you have to do is say, this is a Schedule B drug, not a Schedule A drug, so you don't have to fill out the Schedule A form, and you just continue to complete the questionnaire on the internet, on the TGA website, and just fill out all the questions. And the questions are really straightforward, like, why are you using this drug? And it's basically gives you a drop-down box as to which cause, was it anxiety, is it pain, etc. Then later on, you just say what drug you're going to use and what dose you're going to use and for how long you're going to use it. And it's got all these drop-down boxes. And then you say, and then they'd ask you, well, what are the clinical reasons for using it? And you say chronic pain, which hasn't benefited from opiate use, and this patient's got lots of adverse side effects from opiates, and you've tried everything else like injections and surgery and all that sort of thing, and you put that in the box, and then you just do some identifying data on the patient themselves, like their initials, their date of birth, and then you send it off, and it comes back and it's approved, and then you can use that approval, write the normal script on a normal script pad, send it to a pharmacist that deals with cannabis, which is certainly there's a couple in the Shire, and then you will get the medication.
Thank you. One question more has come in. It's probably quite a relevant one, really. Can you update us on what the role of the geriatric flying squad is, and when can we call for their help in the nursing homes and the help at home, I guess, as well, and especially in situations like this, delirium and dementia?
Yeah. And look, we have our geriatric flying squads, and if there's anyone out there from other parts of our district, we've got 4 geriatric flying squads across the district, but for the Sutherland Shire, we have the South Care Geriatric Flying Squad. The geriatric flying squad is particularly for rapidly deteriorating patients who would normally be put in an ambulance and sent to hospital. So if you've got a patient who's acutely delirious, but they're fairly stable to the extent that they can be managed in an aged care facility, you put a referral out, or the aged care facility puts a referral out to our geriatric flying squad, and during the hours of 8 a.m. to 10 p.m. 7 days a week, one of our very skilled nurse practitioners or geriatricians will go out within 2 to 4 hours and assess the patient, manage the patient, talk to the GP, talk to the families about the treatment. And in 90% of cases, we will be able to manage those patients in the aged care facility. That's what our data has shown, that 90% of referrals patients are allowed to, can stay in the aged care facilities. So we welcome referrals from GPs or from aged care facilities for the either probably could be managed in the facility. We don't manage people who sort of fall and look like they've got fractured hips because they need x-rays urgently. People who've fallen and had head injuries, particularly those who've had on anticoagulation, then they need CT scans, so they need to go to the emergency department. But if you've got a fall without injury and someone's got pain somewhere that doesn't look like a fracture, or they've got a delirium, or they've markedly deteriorated and they're basically a palliative type patient anyway, then you should be calling your geriatric flying squad, who will come and manage those patients in the facilities and follow them up until stability, and then ask the GP to take over. And they usually follow up each day up to 3 to 4 days. We now have what we call our Sutherland Outreach Service, which is SOS, which is basically a geriatric flying squad for the community. So for people in their own homes, they can call the SOS if there's similar situation has occurred. And that SOS, we have geriatricians and very good nurses who go down and do the same assessment, try to manage the person in their own homes. If they can't, they will organise direct admissions to hospital, either the public or the private, which overcomes them going to ED, which is fantastic. The ambulance we work very closely with in both situations, and if an ambulance is called, they'll often call either the geriatric flying squad in the aged care facility or the SOS in the community. And they've worked very closely with us and they know what we do. And they also have markedly reduced the admissions to hospital. So I hope that gives a good summary of our situation. Now, with COVID around, we're very lucky that we've only had 2 cases in the Shire in aged care facilities in the whole time of COVID. And let's keep it that way. But we're really trying to prepare our aged care facilities for COVID in case something does happen, like in Victoria. But again, look, our geriatric flying squads and SOS are active. They will come out and sort the person out, even do the swabs, arrange for the swabs to go to the right places. And because all aged care facility patients who are swabbed become a priority to our pathology, the results will be available within 4 to 12 hours after the swab's sent.
Okay.